Oh, hello. Oh my god. Hello.
Hi.
Oh my goodness. It's been a freaking day, man.
I'm just chilled from being outside.
Oh, I can imagine because you were outside like all day.
Yeah, we had um
Well, we will get started. Welcome everyone to the November EMS webinar brought to you by Northeast South Dakota AHEC or Area Health Education Center. We're excited for Alyssa to talk a little bit about CHW program and how that works with EMS. Um, Before we begin, please make sure that if you haven't, or if there's multiple of you watching from one Zoom, to throw your names in the chat or send me the names of those individuals so we can get certificates out, and then we will hopefully get certificates out for the last couple of months here this week. So, um, if you have any questions, feel free to reach out to me or Sheila as well, and we can answer those, and we'll monitor the chat throughout the session as well too. If there's any questions. So I will hand it over to Alyssa.
Hello, everyone. I'm gonna get my screen shared here, hopefully. All right. Can you all see my slides? I can't see you anymore, so you might have to just verbally tell me if you can see the slides.
Okay, let me.
no.
It's not showing up, so
Okay.
it might have to hover or push. If you push the start button, you can find your Zoom and still have your slide pulled up. Okay, so we
All right.
see.
I can see them now.
Yep, we can see
Okay.
them, but we see your notes if that makes a difference.
Okay. We'll see if we can switch those. Mhm. I'm not sure if I know how to switch that.
Share again. You should be able to share your second screen.
Okay. All right. Is that better? All right, so we're good to go. Okay. Thank you for that introduction, and I really appreciate the opportunity to share about the community health worker program we have here at Brookings Health System. I'm going to share a little bit more about myself, and then I'm going to give kind of an overview of what a community health worker is, how we went about developing the program and integrating it into the healthcare system. I'm going to talk a little bit about how our program has grown over the last couple of years and share some data, and then go a little more in depth sharing what the role of community health workers is and how we incorporated them into EMS. We're also going to talk a little bit about how CHWs and EMS can support each other and enhance patient care. And then towards the end, we're going to go through a few different case studies so that everyone can get a little bit closer of an idea of what kinds of patients are referred to the program, what I do as a CHW, and then what the impact of that is. So a little bit more about myself. I was born and raised in Brookings, and I still live in Brookings. I have a daughter who's 13 years old. You can see her in the picture there. I love to travel. I've been to 8 different countries, which has really given me a love for people of all different backgrounds, which has come in really handy in this line of work, really being able to relate to people of a lot of different cultures and backgrounds, and even people that speak different languages. Some of my hobbies are archery, Legos, photography, baking. I got a community and public health degree at SDSU in Brookings. And then I got my community health worker certification at Lake Area Tech after I took the position here. I have worked for Brookings Health System for 9 years as an EMT. That's where my healthcare career started. And then I took the community health worker position about 2.5 years ago. A few different things I've been involved in are raising awareness around human trafficking, mass casualty incident response, pre-hospital trauma life support, some mental health first aid training, and then PODs, so point of dispensing operations, especially around the COVID time. All right, so we're going to start with what a community health worker is. Community health workers are considered frontline public health workers. They're part of a healthcare team. They are trusted community members. They do typically share similar life experiences as their patients, which help them relate to their patients. They're dedicated to building relationships and connecting with others, and they're knowledgeable about community resources. Our program here at Brookings Health System, we began the development of it in January 2022. We did start under an EMS-based grant. So for about the first year or so of the program, I was working EMS and EMT or EMS and as a CHW. So I'd go on calls, do transfers, and then also have scheduled patient visits on alternate days. We launched the program in March of that same year. So we just took a few months to kind of get the development done and then started the program, and I started seeing patients. We started with a pretty limited referral source to begin with. We were really focusing on high readmission risk patients and then patients who were frequent ED and EMS utilizers. Those were 2 areas that we really just wanted to focus on to get started, with the hope that the program would grow in the future. Our overall goal was to improve patient outcomes by lowering hospital readmissions. So as with anything new, it can be really hard to kind of figure out where you want to start creating a program and how do you go about doing that. Brookings Health System was one of the very first programs that started in South Dakota. So we didn't have a lot of other programs that we could look at in the same state. So we just kind of started by figuring out what our goals and framework were going to look like. We decided which target population we were going to work on. We decided to come up with some different ways we were going to monitor our program success and growth. We spent quite a bit of time figuring out exactly what the CHW's job description and duties were going to be, and then also how the CHW was going to fit into different service lines. So for example, how is CHW work going to differ from what EMS was already doing, what home health was already doing, like the RN and therapies in homes? We wanted to make sure that the programs complemented each other rather than overlap and conflicted with each other. I did a lot of networking with other programs and asking questions. I talked with a lot of people from Minnesota because they have a pretty well-established CHW workforce. So they were very gracious in giving me a lot of their advice. The nice thing about when you're developing a new program is you can really just make it be whatever your organization needs. After we kind of got some of that in place, we did start with kind of the logistics of, well, how were referrals going to be sent? Who was going to be able to refer to the program? What kind of documentation system were we going to need to have in place? And then we just took the leap of faith and we launched the program. It's kind of one of those things where at some point you do just have to start and then kind of figure out the rest as you go. And that was very much so what we did. We had the basics in place and we just knew we would have to allow for some mistakes and opportunities to reevaluate processes as we went along. I'd say for kind of the first year, there was a lot of evaluating what worked and what didn't work and how we need to adjust it and make it fit our needs as well as benefit the patients as much as possible. So as with anything new, it can be pretty tricky to integrate a new workforce, a new program into an already established healthcare system, EMS agency, anything like that. Our ambulance service is part of the hospital. We're independent and city owned, so we might be structured a little bit different than some other EMS agencies on here, but I think I did hear that some hospitals were going to be logging on too. So it's kind of case specific, but for us, what we did to help integrate CHWs into daily work was we really focused on open communication between everyone. I sent out a lot of frequent updates to individuals so that they would kind of know where we're at with the program and what was happening. A lot of exposure, the more times someone is exposed to something, the more they retain about it, just really trying to get the information out there and raise awareness about what the program is and what it was for. I did a lot of participation in special events, so like hosting booths at Nursing Skills Fair, Diabetes Education Day, health fairs, just getting the information out there. I know that there's a lot of different learning styles. So for that reason, we did want to do some visuals and come up with some printed material to be able to hand out to people so that they could have that information in their hands and also hand that out to different patients that they thought might be good fits for the program. So we did that. And then just really a lot of it was being present. I went to team planning meetings, which were held every day, where a group of people would get together and kind of make plans on how to care for the patients that day. Attended a lot of department meetings, sharing about the program. Sometimes I would just hang out in the emergency department and at the ambulance station, just be present and be around in case anybody had any questions or just kind of be integrated into everything that was going on. Very much so encourage open door policy. I like people stopping in, asking questions, discussing concerns, very much so a team effort. I'm just one small part of someone's healthcare team, and the better we can all work together, the more that patient is going to benefit. So again, it really just comes back to that open communication and seeing how what I'm doing can help other departments as well. Wanted to touch a little bit on how the program has grown in the last couple of years. Like I said, we did start with those high readmission risk patients and then frequent EMS and ED utilizers. Since that, we have expanded referral sources to 3 other places there towards the bottom of the slide. A Vera Medical Group in Brookings, the clinic here does send referrals to me. Wound care does as well here at the hospital. And then most recently, the beginning of this year, the OB unit has started making referrals to the program, which I'm really excited about that expansion. When I first started this program here, I got a lot of inquiries about if OB was going to be able to refer patients to me. And in the beginning, they were not able to. So it was excited to see it grow and expand to that area a couple of years later. We are no longer EMS based. The grants have ended and departments did change. So now this program is housed under the community health worker outpatient department, which is a department of one, myself. So it's just kind of a standalone department. It's currently being supervised by the quality department director. I do still have a lot of communication and work with the EMS department as well. I actually was at an EMS department meeting right before this and walked over here. So we actually had a conversation during our meeting about how CHWs are still impacting EMS specifically. And I was able to hear from some of my coworkers there about some of the patients that have really benefited from being part of the community health worker program. In order to grow the program, we really focused on creating those community connections. Worked on becoming a known and trusted community resource that people would look to for help. We stayed engaged statewide, so the Community Health Worker Collaborative of South Dakota had a big part in making our program successful. They really supported us along the way, and I would highly encourage anyone who is thinking about starting a program to talk with the staff there and use the resources that are online that they have. That was not all up and running when we started our program. A lot of the online resources that have been posted to that site are new and things that would have been extremely helpful in the very beginning stages. So there's a lot of great information out there in the state as of now about how to get programs started and grow them. We have worked on a program sustainability plan, knowing that those grants wouldn't last forever, how we were going to sustain this and keep it around for the long term. I do speak with the senior leadership here at the hospital and the board. I have a lot of support from them, sharing a lot of those kind of stories that tug at their heartstrings, really show them the impact of the program can be really helpful for sustainability and growth. I wanted to share just a little bit of data for the people out there that like numbers and visuals. Referrals by source. So as you can see, my main referral source is the inpatient care unit. And then my second main source is EMS and the ED, which makes sense since those are the two referral areas that we started with. And then the clinic here in town, Avera Medical Group and OB have about the same number of referrals that they make to the program. And then a pretty small portion come from wound care. Since we added the OB referrals, my youngest referral, of course, has been a newborn. So I work with an entire age range. My oldest patient is currently 96 years old. So it's all ages, which I love because I love variety. So I get to work on a whole bunch of different things, which is really exciting. I did list the visit types there. I wanted to show that most of the visits that I do with patients are in their home. So being a community health worker, really focus on being out in the community with patients. So for that reason, I try to do mostly home visits or at least face-to-face visits at community locations. Some of the reasons it might be a community location as opposed to a home is maybe the patient's not comfortable with a home visit, or it's possible that situation is not safe for me to go into. So we have to meet somewhere like a local park or the library. I've actually met patients just on a sidewalk before. Really, wherever they are is where I go. I can also do phone visits, but like I said, I do try to be out in the community and have that face-to-face time. So that is the lowest quantity of visits there. We talked about what a community health worker is, but I did want to go a little more in depth on what a community health worker's role is and kind of some of the specific things we do so that you can really understand, what is it that a CHW does. So community health workers provide patient support outside of the health system's walls. We connect patients to health and social services and community resources. I provide guidance for healthy lifestyle changes, education to patients on health system navigation. I do provide some general health education and assist with chronic disease management, assist with problem solving, help promote goal setting and help patients come up with an action plan to implement to reach those goals, act as an accountability partner and patient advocate, and then just overall assist patients with improving their well-being. I wanted to touch on, how community health workers can help enhance patient care. So one really unique thing that EMS and CHWs have in common is that we both provide care to patients in their environment outside of the health system's walls. So wherever there's a 911 call is where EMS is going to go. And I meet people in their environments as well. So that's something unique that we have in common. One significant difference between the two is that, EMS provides emergency short-term care. That's the purpose. CHWs provide non-emergency longer-term care. So they can really complement each other and enhance patient care because patients are able to get that emergency assistance that they need from EMS, but rather than being sent home with no additional support until that next 911 call, they're able to be linked up with a CHW who can provide that non-emergency longer-term follow-up care and prevent some of those unnecessary or preventable 911 EMS usage times is what a CHW is trying to do. I'm sure everybody on here has probably heard of the social determinants of health, but it is such an important thing in community health work that I do like to always show a slide on it. So it's the idea that 80% of what makes up a person's health is determined by what happens outside the hospital and clinic setting. So as you can see from the graphic here, about 40% of a person's health is made up from those socioeconomic factors. 10% is their physical environment, 30% are those health behaviors, and then 20% is actually direct health care. So both CHWs and EMS get to have a unique view into patients' physical environments and also oftentimes get to see health behaviors that patient has that may not ever come up when the patient's in the clinic or the hospital. So that's something that is really important for EMS and CHWs to pay attention to, because we're the ones that are going out to meet those patients in the community, and we get to see and hear things that maybe not are brought up at the hospital or clinic. And so we can really help with a large portion of a patient's health that is not directly healthcare related. Some specific ways that we can support each other: paramedics and emergency medical technicians are really able to identify patients who could benefit from a CHW intervention. Lots of times they're the first individuals who make contact with a patient. They're the ones that get that first look into a patient's environment and where they're coming from. And so EMS is crucial to making that initial referral that hospital staff in-house may not identify as a need. So that is something that they're able to do, EMS is able to do to support CHWs in our work. You're also able to provide crucial information to CHWs prior to that initial visit that can really increase CHW safety. So usually EMS works, in pairs. You work together. As a CHW, I do work alone. So I am going into people's houses alone. I frequently get EMS referrals. And if it is not someone's house that I have been to personally on an EMS call, I will talk to EMS staff and say, hey, just what can I expect when I walk into this house? Is the patient usually alone? Do they have visitors over a lot of the times? Are there any pets I need to know about? What's the condition of the house? Is it a house where you're going to fall through the floorboards? What kind of things should I be aware of to prepare myself before I go into that setting alone? And what kinds of things can I watch for? Those are really important ways for EMS to support CHW's work, just to improve that safety. Community health workers provide a lot of education to patients on healthcare workers' roles and different levels of care. So as a community health worker, I do have the time to sit down with patients and educate them on, what is the difference between preventative care in a clinic, urgent care, and emergency departments. Sometimes you get those patients where they're like, well, I called 911 and I didn't really end up getting any help because it wasn't necessarily an emergency situation. So educating patients on those different levels of care and what the roles are of different healthcare workers can really end up supporting EMS personnel. It can help with some burnout rates by preventing some of those non-emergent, really frustrating calls. So that's one way that I can support EMS staff and really free up their time to deal with emergency situations that they're meant to deal with. There are always going to be some frequent flyer patients. And some of the ways that we can help support each other through those is, if I'm working with a patient and I've found a couple different strategies and methods that work really well with that patient, I can fill EMS staff in on that. So the next time they go there for a call, they can help reinforce it and say, well, this is what the community health worker is working on with you, and kind of vice versa too, just being in open communication between each other for the benefit of that patient so that we can all improve that way. I'm going to go through a few different patient stories. I want to give you a closer look into what specific kinds of patients are referred to the program. What does a CHW intervention look like? And then what are some of the benefits and successes we have seen from these interventions? So this patient, the referral reason was failure to thrive. This patient had very frequent ED and EMS usage. There was a recent death of a spouse, so the patient was now living alone. They had a lack of in-home services and support, unmanaged diabetes, poor diet and eating habits, and later we had found out that they had hoarding tendencies as well. A couple important things to note about this patient was there was actually a local social worker that had worked with this patient for a couple years trying to get in-home services into their home, and the patient refused them every single time for unknown reasons. It wasn't until the most recent hospitalization that it was found out that the patient had that struggle with hoarding, which is why they were turning down all of that help in their home. Actually got 2 referrals for this patient. The first time the patient stopped responding to reach out attempts, and so I was not able to get in contact with them and ever complete a phone visit, which is what they had agreed to with me. And so the patient ended up back in the ED again and was admitted this second time. And so I got a second referral for them. And for that reason, my intervention started with a visit that actually took place while they were still in the hospital before they even left, because I didn't want them to fall through the cracks again when they left. So while they were here at the hospital, I started that relationship and trust building with them. I really used motivational interviewing, those open-ended questions, to just really kind of see where this patient was at. What was the reason for turning down all these in-home services? What was their reason for coming back to the ED and EMS so often? Were they open to help? What kinds of things were going on in their life that was causing this? We spent quite a bit of time during that initial visit building that relationship, and we talked through a lot of the feelings the patient had had. This was the first time they'd ever admitted that they had hoarding concerns, and I have had family members that struggled with that as well, so we were able to relate kind of on that deep level, which was really helpful. And just talking through with the patient some of the feelings they were having, the shame, the guilt, I was able to connect with them and really let them know that they weren't alone in this and there was help available. So it just really goes to show how important building a foundation of trust is with a patient to be able to benefit them later. After I left that initial visit with this patient in the hospital, they had agreed to home visits with me. So we had set that up before I left, and it wasn't long after I returned to my office that I actually got a call from case management in the inpatient care unit that after my conversation with the patient ended up agreeing to all in-home services that were offered. They were able to understand that, their house was not going to get taken away and that we were really there just to support them and help them. And it was a major breakthrough that had been several years in the making. And so that was something that everyone was really excited about. So I did go on to do home visits with this patient. We worked on appointment scheduling and follow through, getting that home health set up to come in and do things for the patient, worked on an emergency response system referral. I did help get the patient reestablished with mental health counseling. And then the patient actually ended up letting me do a referral to someone who specializes with hoarding situations. The patient was willing to work on that at this point and let that referral be made. So some of the successes and impacts this had on the patient, I do want to note that this was very much so a team collaborative effort. I worked with physical therapy, occupational therapy, the home health nurse, some family got involved at this point. We all really worked together to impact that patient's health. And the goal was, to prevent those ED visits and that EMS overusage, to free up EMS for emergency situations, take some of that load off hospital staff, and just deal with as much as we could in the patient's environment. So the patient did see a significant decrease in ED and EMS usage. They did get reestablished with a mental health counselor and saw them weekly. They started attending all their doctor's appointments. They did start working with the hoarding specialist on cleaning their home, and some of the results of that were that they were able to clear out some different spaces in their house. So they were able to actually access their laundry room again. So they were able to wash clothes and have clean clothes to wear. They were able to access the shower and bath in their bathroom and get the plumbing fixed. They had been doing sponge baths for over a year because they weren't able to get to their shower and tub, and then also didn't want anyone to come into the home to fix it. So because of that help from that hoarding specialist, we were able to get some of those issues taken care of so that now the patient's in clean clothes and able to bathe, which through the help of therapies, they're able to do independently now. They have access to an emergency response system, and they're receiving 60s plus dining hot meal delivery, which really helped with their poor eating habits. They're now getting regular hot meals, a more balanced meal each day. And the patient actually ended up improving significantly enough that they were able to return to driving, which is just a major breakthrough. The patient, now that they're able to drive again, their independence has increased, their self-sufficiency. It's a lot easier to get to follow-up medical appointments. They're not as isolated because they can go to community activities. Just getting a lot of those other things taken care of for the patient really benefited them in just a lot of different ways. I have a second slide here to show the impact on this patient. So this patient did have unmanaged diabetes prior to all these interventions, but now they're effectively managing that condition. Those 60s plus dining hot meal delivery, they're having that balanced nutrition each day. They're more compliant with their medications. I was able to work with them to figure out what's kind of a system we can come up with so that you're able to regularly check and log your blood sugars. That was something that they were just not remembering to do. So we came up with a plan together of, well, let's try this and see if this can help remind you to do that. If that doesn't work, let's do something else. And so they did get to the point where they were checking it regularly and logging it. And after some time, the patient had their A1C checked again, and they noticed a significant decrease in it. So this was a huge win for that chronic medical condition for this patient. All right, so this patient was referred because of inappropriate use of EMS services. They had very frequent use of both the EMS and ED services, a lot of phone calls, as well as visits to their house for non-emergency reasons. They had a lot of anxiety, specifically around health-related issues. So they would get concerned and then they would call EMS to come check them out and take them to the ED because there was just a lot of anxiety there. They're very focused on negatives in their life, which caused them to become isolated and lonely, a lack of a support network. All of this contributed to no-shows to medical appointments, and they were low resource and had a lack of transportation. So again, my work with this patient started with building rapport and trust. They had kind of a rough history with EMS and ED. So we did work a lot on building rapport and trust so that they would allow me to help with other things. So a lot of our first visits together were just getting to know each other, kind of figuring out what this person's about, what kinds of things do they like, really building that relationship so that we could work on more focused things later on. After that, foundation was built, we worked on healthy anxiety coping techniques. What can we do to manage these symptoms of anxiety that are causing you to call EMS for non-emergent reasons? What can we do instead? What should we try, 1, 2, and 3 before we get to the point of having to call? So we worked on that over an extended period of time. We also really worked on a mindset shift. So they were very focused on negatives. Something that I do with a lot of my patients is we do gratitude journals together. So I give them the resources to do a gratitude journal, and every day their homework is to write something that they're grateful for. So we can kind of shift that mindset away from the negative and focus on something positive, which is a benefit to them. I did some referrals to community events so that if they would like to, they would know what was going on in the community so that they could go out and attend these events and become less isolated, which grew their social support network as well. We did a 988 hotline referral, which is the suicide hotline. However, it can also be used in situations where someone has a lot of anxiety and depression and needs someone to talk to. So kind of rerouted some of those calls to 988 when it was appropriate, as opposed to 911, really educated the patient on, what kind of scenarios would you call this number for, as opposed to this number. Just really taking the time with that patient to educate them on all these different things. I did some transportation assistance as well with this patient so that they would have the opportunity to attend community events. And then with this patient, I don't do it very often, but I do have the ability to attend appointments with patients. So if they're set up with like a new doctor or specialist, sometimes I'll go with them for that first visit to help with some of that anxiety about meeting a new healthcare professional, and kind of just help teach people how to speak with healthcare professionals. I help them come up with what kind of questions do you want to ask. So just kind of worked through some of those things with the patient. So this is a fun impact to talk about, because this is actually one of the patients that had come up in the EMS department meeting that I was at right prior to this presentation. And my coworkers again said that, my work with this patient really had a huge impact on both the patient and EMS. So there was a significant decrease in the patient's inappropriate use of EMS and ED. Their call volume went significantly down, and they rarely call anymore, which is again freeing up EMS to do the emergency calls that they're getting. Some of the other benefits we saw from working with this patient is that they're regularly using that gratitude journal. It's easier for them to come up with positive things to say as opposed to negative. They did have a decline in no-shows to follow up in preventative appointments. They are more likely to attend those after intervention. They have an increased support network. They do have access to community events that has eased their isolation and loneliness, and improved access to transportation. This is the last story I wanted to touch on real quick here. This was a patient that, again, had inappropriate usage of healthcare services, including overusage of both EMS and the emergency department. This patient was actually seeking all of their medical care from the emergency department because they did not have a primary care provider established. They had no insurance, poor living conditions, decreased mobility, mental health struggles, and a lack of adequate food. So there were a lot of different things contributing to this person's health that needed to have some sort of intervention or assistance provided. And one thing I did forget to list there was that this patient did have a lack of transportation as well. So I had found out that part of the reason they were seeking all of their care in the emergency department was because they didn't have a primary care provider. But the other part of it was that they didn't have reliable transportation. And so they were using EMS as their transportation to get to the ED for care, because they said, how am I supposed to get to the clinic? And so that was an issue as well for this patient. So let me go to this slide real quick, and then we'll go back to the other one. So for this patient, I do an in-depth assessment with all patients, but for this one, it was a little bit extra complicated. There were a lot of different things at play in this patient's life, so it was quite complex to sort through, and it did take quite a bit of time. But I focused really heavily on educating the patient on the appropriate usage of healthcare services. This was a patient who was a really good example of just not having the understanding and knowledge of what is preventative care. Why do I need a PCP? What kinds of things would I go to urgent care for? And what is an actual true emergency that I should call 911 for and have EMS and ED provide that care to me? So we went over that a lot. I would sometimes provide example situations. If this was to happen, which one of these three places would you seek care from? So just a lot of educating the patient on the appropriate usage of healthcare services, which some of those things do take a lot of time, and community health workers can kind of help fill some of those gaps because other healthcare providers are busy with other things. And so we can kind of help fill some of those gaps with those things that are education based and take a lot of time. I also helped this patient apply for Medicaid so that they could have health insurance coverage. We worked through some medical debt and financial insecurity, arranged reliable transportation, got them set up with some community transportation so that we could eliminate them using EMS for the sole purpose of transportation to a healthcare facility, redirect that to the clinics, got them referred to a primary care provider, some assistance with prescription medications, affording those. We worked on their home environment and improved some aspects of that. For example, I had found out that the patient had been sleeping on the floor because they didn't have a bed. And if you remember, this patient had some mobility concerns. And so sleeping on the floor is really hard on your health overall. Sleep really impacts a person's health. And so when you're not sleeping good, your health tends to be a lot worse. And this patient had been sleeping on the floor for a very long time. And that was one of those things where it's like, I wouldn't have known this patient was sleeping on the floor unless I had gone to their home and said, hey, where's your bed? Because it's one of those questions you don't necessarily think to ask when they're maybe in the emergency department or the hospital. It is a question I've added to everyone's assessment now, regardless of where I meet up with them. But I was able to get them a bed and set up with some consistent food resources as well. I got my slides mixed up, so I'm going to go back to this one. So the impact for this patient was that they had reduced usage of EMS and ED. They're more appropriately utilizing healthcare resources. They did end up with a sufficient food supply at the end of my intervention. They were set up with Medicaid and had health insurance, established with a primary care provider, was able to work with clinic staff to actually get this patient set up with a PCP that wasn't accepting new patients, but who was specialized in some of the conditions this patient had. So they made an exception, which was really to the benefit of this patient. The patient was set up with mental health services, now had reliable transportation. Their sleep improved, which improved their overall well-being. Throughout all of these improvements, their self-confidence increased. And then my favorite one is listed last. Throughout all my work with this patient, they had been using a walker everywhere they went. And after we made some of these adjustments and improvements, they actually ended up getting to the point where they weren't using an assistive device at all. So they went from using it absolutely everywhere to, well, now I don't need it in my apartment. I only take it when I go out, to now I don't need it anywhere. So that was a really significant thing that changed for this patient. I'm just going to touch on this really briefly. It is posted on the Community Health Worker Collaborative of South Dakota website, which I listed there if you want to read it in more detail. But this just kind of shows an example of cost savings and return on investment for community health workers. So the CHWSD are the ones that calculated this for us. But for every $1 spent on CHW expenses in the case scenario that I just talked about, we saw a return on investment of $74. and we had a cost savings of over $25,000. So that really helps with the sustainability of the program to show some of those kinds of numbers and how it impacts us financially. I didn't want to do a specific case study on any of these, but I did just want to mention these successes. There was a patient that I worked with who had a very dilapidated porch and steps and didn't have railings in the front and back. And they had actually said that EMS had said it was a very unsafe situation, both for EMS and the patient themselves. Steps were very narrow. So EMS was at risk, the patient was at risk, and I was able to work with that patient and get a program involved that actually just recently replaced their entire deck, all the steps, and added railings as well. So through working with that patient, the safety of both EMS and the patient was improved. There was another patient I worked with. My main focus with that patient was helping them to get health insurance. And by helping them get that health insurance, Brookings Health System ended up being reimbursed with over $74,000, preventing further medical debt for the patient and also preventing us from having to write off some of that expense. So we were able to recoup some of that by me working with that patient. The last one I wanted to mention was an elderly patient that I was working with. This elderly patient had called 911 multiple times for the nebulizer not working. And this was one of those problem-solving situations. So it turns out that this patient actually had 2 light switches in their living room. One turned the lights on and off, and one turned the outlets on and off. So when the patient would mix up the light switches, they'd actually turn off all the outlets, and the nebulizer won't work if it's plugged into an outlet that's turned off. So this is one of those situations where it just took some time to figure out what the problem is. And then let's problem solve it together. So we ended up just blocking off that light switch with a note that said, do not use, you need to leave this on. And so now the patient doesn't mix up those light switches, their nebulizer works, and it's prevented those calls to 911 for breathing concerns because they're back to using it regularly as prescribed instead of missing doses due to it not working. Okay, so I'm at the point where if anybody has any questions, I just tried to kind of provide a big overview of what we're doing here with the community health worker program. I'll take questions now, but also if people have questions in the future, something more specific maybe that I didn't cover or you think of later, please don't hesitate to reach out. While I answer any questions there might be, I'm going to leave this slide up here just so people have enough time to write it down if they want to. You can email me, call me. Direct office line there, and work cell is there as well. So I love asking questions. I am a big question asker, so I also like answering questions. So please, if you ever have a question, even after tonight, please go ahead and get in touch with me. And if I can't answer it, I'll try to find somebody that can.
Alyssa, can you talk a little bit about, you said you went to Lake area for your community health care worker education. Can you explain a little bit about that?
Yep. So what I did was I did a semester-long certification. I did it while I was working a different part-time job. The one that I enrolled in was all online, which makes it a lot easier for non-traditional students. Some of us are that are maybe already working, done with school, and we just want to go back and do this. So I did that. It was one of the first times they offered the certification online. So there were a few kinks to work out, but it worked really well for me having it all online. I only had to go to Lake Area Tech for the graduation, actually. I know that there are different options out there. I believe Southeast Tech has a program now as well. And there's like accelerated programs where you can get through it a little bit faster. So there are choices for people now. sometimes I wish I could go back and retake those classes, because now that I know what I'm doing, I think I'd be able to apply those things a little bit better. Whereas when I was learning all of it, I'm like, I don't know how this applies because I don't know what I'm going to be doing yet. But there was a lot of case scenarios that we got to do in class, a lot of mapping out community resources, helping us learn the resources in our community. I know that now, not when I took it, but now part of the training is doing an internship with places that have established programs so that you can see how their program runs. And every program is so different that that's really beneficial to students that are going through it now. Any other questions?
I guess one question would be, what's the most rewarding part of your job as a community health worker?
Oh, man. Well, I just really love what I do. I mean, I love EMS work. You know, that's why I got started in the healthcare field. But there were parts of it that bothered me. You know, it's hard as an EMT. You don't get that follow-up with patients. You don't really know what happens to them after you take them to the hospital. You know, being in their homes, I'd noticed things, oh, there's so many things here that I could help with, and I couldn't in that role. I love EMS. I continue to love it, and the aspects of it. But one of the most rewarding things about what I do is being able to kind of go that extra mile and help patients with some of those things that there just isn't anybody to help with. You know, community health workers can really fill those gaps for people. And I would just say some of the things that I worked with patients on for a really long time, like that deck and stairs that we got replaced, we'd been working on that for about a year. And so it's really rewarding to see that actually happen and then make such a huge difference in that patient's life. So it's just really exciting to see how far people come from the start of the program to being discharged from the community health worker program.
Awesome.
Any other questions?
Is Lake Area the only place that offers this certification?
So as far as I know, Lake Area and then Southeast are the two that I've heard the most common. I haven't gone on and specifically looked, but a lot of there are, I believe, 5 of us CHWs in Brookings now. We meet monthly, and a lot of them went to Southeast for it. There is some continued education that comes along with being a CHW if you're going to be registered with Community Health Worker Collaborative of South Dakota as well, but it's pretty minimal, and there's a lot of education that's available to be able to meet those requirements. So it's fairly easy to stay certified if anyone's ever worried about staying caught up with that. It's very, very doable. I know I talked a little bit about kind of the sustainability plan, which has been on a lot of people's minds, just because all the grants did end. There are other grants out there for more specific things that some CHW programs are incorporating in. For us, we did recently start billing Medicaid. Medicaid does reimburse for CHW services. So we do bill Medicaid patients. For everyone else, it's a complimentary service that the hospital provides, because we've seen enough cost savings, not necessarily bringing in money. There are the situations where helping get a patient on insurance, we then get claims processed for services that we provided. So that's bringing in income, but also just cost savings, you know, preventing those readmissions so that we prevent those Medicare dockings for those readmissions. You know, for inpatients, I'm trying to keep patients out of the hospital for 30 days or more. And for ED, it's 72 hours. So we really look at it as like a cost savings and preventing the loss of money, not necessarily making it.
Are there any CHWs around in the northeast part of South Dakota, specifically Aberdeen area?
So there is a map on the Community Health Worker Collaborative of South Dakota website. I think it's something the public can access. Some of the parts are like members only, but it has a whole map of where CHWs are, which is helpful because yes, like you're talking about, sometimes we get a patient in the hospital that maybe is from Aberdeen and they make a referral to me. Well, I cover a 30-mile radius. So then I look for a community health worker elsewhere that covers that area to refer them to. So there is a system in place to be able to locate community health workers in other parts of the state. Yes.
I
So-
will throw the link in the chat because I was able to find it. for
Perfect.
that.
Were you able to access it just as a non-member?
Yes. Yep.
Okay, perfect. And not everybody has like their contact information listed there if they don't take outside referrals, but at least can show you like where they are located.
So question for you, Alyssa, when you
Yes.
said that you're able to referral. So I'm just thinking, you know, my ambulance service, we do bring patients to Brookings, but we're not in the same county. And I know I see another person that is probably brings patients to Brookings as well. If we have a patient that, you know, we've been called to frequently in our community, can we call you up and say, we feel like this patient needs your services, or how does that work?
So it's kind of case by case basis. So they do have to have some linked to Brookings Health System. I don't take outside referrals that aren't linked with us in some way. So like if they have had a recent ED visit, I would most likely be able to get a referral for them if you made it known. I could pull them up and see how recent was that visit, you know, that sort of a thing. If you're going to them frequently and not bringing them to Brookings for the way our program is set up, that wouldn't be a referral that I would be able to take because they're not linked to Brookings Health System. But like if they're coming here for wound care or they've been admitted recently, those are patients I can take. If their primary is at Avera in Brookings. Does that answer your question? So that's why I say it's kind of case by case because it kind of depends on if they've been in our hospital for something recently.
Yes, that
Mhm.
helps.
Yep. So if there's like a specific concern, I can pull them up and see if there's anything recent we could connect it to. And then I'd have to run it through, see if someone would be willing to do that referral.
Okay.
I've never been turned down for a referral. A lot of providers are really for these programs because they see the benefits. So I've never had a provider turn me down when I've requested a referral, like from the clinic or somebody here at the hospital.
Okay. I probably will be reaching out to you.
Okay, sounds good. Yeah. Yeah, I'm more than willing to, you know, look into it and see if they're a patient that we'd be able to incorporate into the program. You know, sometimes I'm super busy and sometimes I'm not. So every once in a while, there's points in times where I really can't take anybody new on. But it just kind of depends, kind of like EMS, you know, sometimes you're busy and sometimes you're not. And it's hard to say what those times are going to be.
Okay. Perfect.
Yeah.
Alyssa,
And
I
so
have a
that's-
question.
Yes, go ahead.
Is this like, do you have an average 40-hour week or is it a part-time 30? What is your average week hour wise?
Yep. So when I took this position, I requested 30 hours. So I am well, part-time at 30 hours is what my position is. It just depends on the organization if they want. I think Sanford's is full-time. I think Avera Behavioral Health is part-time in Brookings, so it just kind of depends. I personally requested 30 hours because that's what fit my life at the time, with being a single mom and stuff. I do have flexible hours because there are some patients that I see that have jobs and work until 5. So every once in a while, I do work an evening, I'll stay till 7 or 8 so I can see those patients. So my hours are very flexible in that way to fit what is needed for the patients. So, if I work late one night, I might come in later in the morning the next day. So there is some flexibility there, with the kinds of patients that I work with, I'm never going to ask them to skip work to have a visit with me because the point is to make them self-sufficient and we want those good things in place. So yeah, that's where I'm at, 30 hours a week and keeping those hours flexible to fit patients' needs. And I know a lot of people tend to ask about caseload as well, which varies a lot. As I discharge people from the program, I admit new people, so it can go up and down a lot. From the research I did before starting this position, it sounded like 20 to 40 active patients at a time was a pretty typical caseload, but it varies depending on how much time is required for those patients. So my patients that are not English speaking, with the use of a translator, those visits are twice as long. Lots of patients I may be working on one thing with them, and then this patient I'm working on 10 things. So it's not really about the number of patients that are enrolled in it. It's, what's being worked on with those patients that determines my caseload that I'm able to have at any one time. Any other questions? I can't see the chat. I'm assuming there's probably no questions in there,
Don't
but if
see
there
anything in the
are,
chat either.
okay, perfect. I just can't see it.
Awesome.
I don't want to miss it if somebody did put something in there.
Yes. Well, thank you so much. We appreciate it. And yeah, it's exciting to see how this role has kind of developed into what it is now.
Yeah, I appreciate the opportunity to share about it, and really encourage people, if you think of a question later or would just prefer to chat about stuff one-on-one, we can set something up and I'll get those questions answered for you.
Awesome. Well, thank you, everyone. Have a good evening.
Bye.